Oh, come on, Bob. I ain't gonna let you out. Do you like corn?
Yeah.
Could I ask everybody to make sure that they're muted? We can hear some background noise. You can hear the radio in the background. So if people could mute themselves, please, before the presentation starts.
Where is it?
Thank you. I think that's better. Okay, I think we should start. People can join as they come along. So first of all, I just want to introduce myself. I'm Frances Elmsley. I'm a clinical geneticist at St George's, and I'm clinical director for the South East Genomic Medicine Service Alliance. And I'd like to welcome everybody that's joining us today for the second of our genomics festivals. So we started off in the spring with a focus on certain rare diseases, and now we have our autumn festival today with a focus on cancer. And I'd like to thank upfront all our speakers for coming along today, and also our organising committee who've put an awful lot of effort into this. So we will kick off, first of all, with an introduction of somebody that I'm very excited to introduce to you. So Makeda, could I have the next slide? Thank you. So people may be aware that this week is National Inclusion Week. Alongside the other work that the Genomic Medicine Service Alliance has been doing, we have been ensuring that we access all our communities, and through our recruitment and representation in the Alliance, we want to ensure that all groups are represented. So we have established a strategy for inclusion, equality, diversity and inclusion. And we have been successful in appointing our independent chair, and I'm delighted to introduce Sarah Maskell to you. Sarah sadly couldn't be with us today. She did want to be here today. But Sarah comes from a background of 20 years in the RAF, ultimately serving as a wing commander. And in the last 6 years in the RAF, she worked as a policy specialist, changing the equality and diversity space in the RAF. She then went on to work as a relationship manager at HSBC, and then on to the Home Office to lead the department's commitment to diversity and inclusion reform driven by the Windrush scandal. She was appointed at board level to a new role in GSTT in 2022. So she has a huge background in ED&I, and I think we're really lucky that she has agreed to be our honorary chair. She has outside work a huge range of contacts and uses them to discuss and share good practice. And she recognises the challenges around equity are common across the board. So I don't think there's anything particularly special about genomics, but we need to get it right in genomics. And so she sent us this message, which I'm just going to read out. But she has said, "I'm delighted to have been afforded the opportunity to chair the ED&I board and to contribute to the ongoing development and integration of equality and equity, diversity and inclusion across the South East GMSA. The early work by GMSA colleagues in identifying and shaping a direction of travel and some ambitions is an impressive starting point and one which we will build on in the coming months. I see the opportunities in the work of the South East GMSA to increase transparency and improve access to a talented workforce, to use our experiences to transform our service and to improve the outcomes for current and future patients. I look forward to working with you all soon, and have a great festival. So that's the message from Sarah, and we will meet Sarah again in future festivals. So next, onto the main substance of our talks today, and I would like to introduce Dr. Nirupa Murugesu, who is a consultant in medical oncology at St George's, but also cancer lead for the Southeast Genomic Laboratory Hub and the Alliance. But she is also clinical lead in cancer genomics and clinical studies at Genomics England. So she has a huge portfolio. And thank you very much, Nirupa, for agreeing to talk today, and over to you.
Thank you, Frances, and for the opportunity to talk today. I'm going to be discussing and giving a bit of background in terms of how genomics is impacting cancer. And I suppose we can think of cancer as a disease of disordered genomes. So if we're looking at these different molecular lesions, we are finding more and more, both within solid and hematological malignancies, that this is impacting diagnosis, prognosis, and importantly, more personalized therapies, so precision oncology, so tailoring treatments based on individual tumors, and also in terms of disease monitoring. So the use of genomics, as many of you will be aware, is continuing to expand within cancer. And so if we look at the inception of the new genomic medicine service, and we look at the impact of next generation sequencing, so a technology to enhance the ability to look at all of these different genomic alterations, we know that there is now a published, this is available, publicly available, National Cancer Genomic Test Directory. And within this directory, and this is being updated regularly, we are, based on evidence, we can begin to see which are the particular tumor types for which certain types of testing, genomic testing, should be undertaken. And the way that within England, this is being delivered through 7 genomic lab hubs. And then the ability for next generation sequencing, be that through large cancer panel tests or whole genome sequencing, is the ability to call the different types of genomic alterations. And these are then reviewed within a genomic tumor advisory board. So in the context of the clinical information, and with the genomic results, then a clinical interpretation is provided to the treating clinicians and tumor-specific teams. So I thought maybe I could highlight this with a specific example, and which is known as a poster child, if you like, in molecular testing in solid cancers, and that is non-small cell lung cancer. And within the test directory, there are a number of different alterations that should be tested for at diagnosis as part of gold standard treatment. So this is listed here, and this list is likely to expand as there are more and more targeted and NICE approved therapies becoming available. And I think the issue is that you have a small biopsy sample, and this is the current practice for which we can make a diagnosis. So and Nish will, Dr. Nadia will be discussing this in more detail, but you've got immunohistochemistry to confirm a cancer diagnosis. And then, as you'll see in this particular example, there are different types of genomic alterations that should be looked for and tested for. So this may be small variants, so single nucleotide variants, copy number changes, and also fusions. And this is in keeping with the test directory. For certain tumor types, additional testing may be required in the form of tumor mutational burden, homologous recombination defects and microsatellite instability. So this is just to give an example of where further testing may be required, and similarly with cytogenetics, especially in certain types of cancers. And importantly, we may also need to look to see if there is an inherited risk for this tumour type, and also more and more it is envisaged that more testing will be required in terms of pharmacogenomics. So looking at, for instance, within the test directory, we have DPYD deficiency that's tested for in any patients that will be receiving a fluoropyrimidine treatment, so that you adjust the treatment doses according to individual genotyping. And essentially, in order to allow this, and this is the sort of future direction of travel, is that next generation sequencing or whole genome sequencing is a single test potentially that can try and capture all of this information, rather than having lots of sequential tests, especially when all of this information is required in order to make an informed treatment decision. There are a number of caveats, though, in terms of how is this transitioned, how do we deliver this, and they're listed here in terms of considering things such as having enough tissue, the performance of the test, the turnaround times, etc. And more and more we are seeing that if you've got more tests, then the tissue volume is also an important aspect, and we'll come on to discuss that. So I'm just going to give an example from a whole genome analysis from the 100,000 Genomes project. This is from the cancer program, where we have a patient, and you'll get some information, and this is similar to the reports now that are available within the NHS, and you'll have information about the tumour type and the histological subtype and important quality metric information, sequencing quality information. And then, similar to a large panel, there are a number of what are labelled as domain 1 actionable variants that can be identified. And these are looked both at the gene and at the variant level, and this is often looked at within our Genomic Tumour Advisory Board to consider actionability and potential studies. And then I think the point that I wanted to really emphasise is that we are very much at the moment used to looking at small variants, so a single base pair change. But I think as we gain more and more information, it is not just looking at that small variant change, but looking at copy number changes and looking at the genome as a whole, looking at fusions, especially when there are cancers where there are a large number of fusions that are relevant both for diagnosis and for treatment, sarcoma being one, and that is why that has been commissioned for whole genome sequencing within the NHS. And so it's really to get information about what's happening to the cancer genome as a whole. And this is the sort of information that we're beginning to look at in more detail now. So this is a circus plot that allows us to visualize from chromosome 1 all the way to 22, in X and Y, what the genomic architecture is like. And you can also begin to look at mutational signatures. So these are the patterns of mutations, and that often will give an indication of etiology, but may also be important in terms of treatment. So if you look at mutational signatures such as what's known as signature 3, which indicates whether there may be a homologous recombination deficiency, and that may be relevant in terms of treatments such as PARP inhibitors. So this is how we begin to get an overview of the genome. And I suppose here a picture sort of speaks 1,000 words. So if you look at things, and if we look at them in terms of pan-genomic markers, we can begin to see that this tumour is very different from that one. You don't need to be looking at cancer genomes regularly to be able to see that. And that's because here on the left is an MMR deficient tumour where there are a high number of mutations indicated by the solid red and green tracks here, whereas this is an MMR proficient tumour. And this also has implications in terms of treatment. And the other thing that is likely is an imperfect biomarker, but is likely to be more and more in use, certainly being used in the research setting, is tumour mutation burden. And we can begin to see what the different mutational burden is across different tumour types. And we can also see how that is relative to the individual tumour. So that's indicated here in the dashed horizontal bar across, and the median you can see across different tumour types here. And there are certain tumour types, such as in lung and malignant melanoma, where you see a median high burden of tumour. And really, why is this important? Well, here in the dashed box above, we know that potentially in those patients that have a high tumour burden, they are more likely to respond to immunotherapies. And so as we get more and more evidence, and this varies by cancer type, so I will caveat that, but there will be refinement in terms of calling which are the patients that are likely to respond to immune checkpoint blockade. And then, as I sort of briefly mentioned, we can begin to see mutational signatures across different tumour types. So we know that in melanoma, we see a signature that is caused by exposure to UV light, which signifies the underlying etiology in melanoma. And similarly, we can identify a smoking signature within lung cancer, again, indicating etiology. And as I mentioned earlier, within ovarian cancer, and this is now within the cancer test directory, we can, patients should, with high-grade serous ovarian cancer, they should be tested for homologous recombination defects, as they may benefit from PARP inhibitor therapy. So this is, some of this is directly applicable to treatment, and some of this is still within the research setting, but you can begin to see how these pangenomic markers will be influencing cancer treatment in the future. And then I think the important thing to remember is that when we're looking at, and I mentioned this briefly earlier, when we begin to look at cancer genomes, we should be considering both what we call the somatic genome, so from the tumour sample, but also the germline sequence. And so in terms of whole genome sequencing, we look at both of this, and there is a subtraction. So you look at tumour variants and you take away the constitutional variants, and to give the calling of what's likely to be a somatic variant. And I suppose more and more, and this is covered both within the rare disease test directory and the cancer test directory, that we'll be looking for potential looking for germline variants, and these will be picked up either by germline testing or by panel testing, where there will be a suspicion, and then further confirmatory testing will need to be undertaken. And then I think the important thing is, and we've certainly found this from our experience within Southeast, is that the more and more that we are able to provide clinical interpretation, be that for large cancer panel testing, circulating tumour DNA testing, which Deb Sarkar will be discussing later on, as well as whole genome sequencing, alongside the clinical information, really allows us to review cases and look at all of the information, look at the different types of genomic alterations that have been identified, and then provide recommendations to the treating clinician, and also to consider potential clinical trials that are available. So I'm not going to discuss this case in more detail, because Deb Sarkar will be coming on to discuss this in terms of how this has impacted this individual patient, for instance. So I will pause there, and I would be happy to take any questions in the chat box, and I will hand over now to Nish Naidu.
Thanks, Nirupa. Sorry,
there's a bit of IT issues here, but so my name's Nish and I'm a pathologist based at King's, and I wanted to shift focus slightly to focus on how genomics is changing cancer pathology. So I think the main difference between looking at rare diseases and particularly solid tumors is that tissue is the single most important determinant of the data that you get. We're not always sequencing blood, we're really taking tumor tissue and looking at it. And I think pathologists play a central role in both the pre and post analytical phase in this process. So as Nirupa mentioned, we're involved in diagnosing the cancer. We quantify tumor cellularity, which is really important in terms of characterizing the tumor and putting it in the context of the genomic alterations that we see. We take what we find scientifically in the genome and integrate it with the clinical data that we know about the patients. And increasingly, molecular pathology and genomics is being seen as another tool in the belt of the pathologist. We're not just there to make morphological diagnoses, but we want to know about what's happening at a molecular level. And indeed, the Southeast Genomics Laboratory Hub is, I'm proud to say, trying to grow the next generation of morphomolecular pathologists, which is really important. But as Nirupa said, we're starting to expect more and more information from relatively small amounts of tissue. And that presents us with a number of challenges. So I think, Makita, can you go to the next slide for me, please? It doesn't seem to be working for me. Thank you. The first challenge that we have is the specimen request form. And I just wanted to take a moment to chat about this because it's something that we face every day. And pathologists really interpret in the context of what we're told. So I think we forget that when we fill out these forms, you're actually asking for a specialist opinion on what's going on with this patient. And how you provide information really determines how we handle the tissue. So, for example, if we go back to the example of non-small cell lung cancer, it's important to know if there's a history of cancer somewhere else because the lung is the seat of a lot of metastasis. And if I know that there's a lesion elsewhere in the body, I'll do far more IHC, which limits the amount of tissue that I can use for genomics. Not all pathology is cancer related, and a lot of benign pathology happens in the lung. So if I see a granuloma on a section, I won't necessarily go looking for cancer because there are other causes for granuloma. But if you flag it for me in the specimen request form, I know that I need to do a little bit more work. And then, other examples are, where is the lesion in the lung? So, if I have a tumor that's sitting in the pleura and I've taken a pleural fluid sample, I'm more likely to see cancer there, and I'm not, worried about missing the lesion. So sampling error comes into it as well. The second challenge that we have is in terms of tissue handling, and I wouldn't be a pathologist if I didn't include some really gory pictures, so apologies to those who are sensitive. But you can see that tissue comes in many flavors, and any human tissue that comes out of the body has to come to a pathologist to be made into a slide before we can analyze it. So for example, here's a lung lobectomy specimen, and you can see there's a nice central tumor. This is a smaller piece of lung. It's called a wedge resection that's been taken out for benign bullous lung disease. But so this comes into the cut-up room, and a pathologist will look at it and say, okay, I'm going to take 8 to 10 pieces of tissue from this tumor to answer all the questions that the clinician has to wants to know about. So for example, has it been completely excised? What kind of a tumor is it? Is it invading into the pleura, etc., etc.? And from this big piece of tissue, we end up with a block of tissue this size that has been formalin fixed and paraffin wax embedded. And as Nirupa mentioned, we're trying to get increasingly more and more data out of these pieces of tissue. So this block will then be sectioned at 4 to 5 microns and put onto slides like this. And as you cut into the block or level into it, which is the term that we use, you start to run out of tissue. And you can already see that there's different sizes of tissue that you get. So in an excision sample, you can take nice big chunks like this. But in needle core biopsies, which are shown here on the top, you can see that you're already dealing with smaller cores of tissue. So this is a core biopsy that was taken from a lung, and you can see that there's nice tumors that are forming acinar structures, so an adenocarcinoma. It's well differentiated. But here's a piece of liver that has a very poorly differentiated tumor coming through it. So formalin gives you nice morphology, which is great. And then we have to do some special stains to make sure that the tumor is what we think it is. So for example, an adenocarcinoma will express TTF1, which is shown here. So we know that it's an adeno. And only once we fulfilled these steps can we send tumor for nucleic acid extraction. And as you all know, formalin fixation impacts on the quality of DNA and RNA that you get. So already we're starting to make trade-offs between all of the things that we need to do. The third challenge, as I mentioned before, is size. So in addition to excision and biopsy specimens, you have fine needle aspirates where we stick a very fine needle into, for example, a lymph node, and you pull out chunks of cells. And the morphology is beautiful. So you can see again, we have an adenocarcinoma filled with malignant cells that have mucin vacuoles in their cytoplasm. But you can already see that when you zoom out, you've got a lot of other stuff in the background. So you've got blood, you've got inflammatory cells, and all of these other cells also contribute DNA and RNA to during extraction. So it actually decreases the amount of tumor that you can analyze. So one of the challenges of cytology is low cellularity, and all of the tests that we do have limitations. So for PD-L1, for example, you need to have at least 100 cells to be able to say that it's present, and this will impact on whether the patient receives an immune checkpoint inhibitor. We don't actually know the number of cells that you need or the minimal number of cells you need for NGS. There are some groups that say you need 700 cells, but you can imagine if we think back to the excision sample and how big that tumor was, and we consider 700 cells, you're already starting to ask, is this representative of the tumor? So intratumor heterogeneity is a big challenge with genomics. The samples can cut out, as I said, and then the gold standard for cytology is that you have the pathologist in the bronchoscopy suite with the physician, and we give a diagnosis and say, yes, please save everything for molecular. But that, of course, is really costly and not all centers can afford it. So again, there's sometimes a trade-off between what is best practice and what we can do with what we have. So I think Nirupa really alluded to this with her talk, is the big question on everyone's mind is how do we stratify tumors in a meaningful way? And yes, we can do it on morphology. That's been done for, decades, and it's worked fairly well. We can tell, on the way that tumors grow, whether they'll do well or not, how differentiated they are, if they'll do well or not. But we want to include other adjunct investigations, including genomics. So you can stratify tumors based on whether they have mutations or RNA fusions, and those tumors are called oncogene addicted when they're in the lung. As Nirupa said, tumor mutational burden is really a flag to whether or not the immune system is reacting to the tumor or whether a patient will benefit from immune checkpoint inhibitor therapies. And that's a really hot topic at present. But I think in the context of the GLH and the GMSA, what we're trying to do is ensure that the National Test Directory and service provision really evolve according to the needs of our patient and to emerging technologies and knowledge, which is what Nirupa was talking about earlier. So finally, I think the fifth challenge that I want to mention is formalin fixation. We all know that formalin gives pretty morphology on H&E, but doesn't actually protect DNA, and probably RNA is worse. And this is important in the context of many tumors, as Nirupa already said. But one of the major challenges that I face as a pathologist at present is trying to get fresh tissue pathways up and running, because it really is a real mind shift and a change in practice. But I'm glad to say that we're starting to share expertise and experience across the country, and there's a good network of pathologists that are now talking to each other. And I hope that in the next couple of years, this is a space that really starts to grow and develop. So finally, can we forget about tissue entirely? It won't surprise you that I would say no. But I think that there are emerging exciting technologies like ctDNA, which provide us with alternatives when tissue can't be accessed. And for the moment, we should be doing this in parallel to the gold standard of tissue diagnoses. But maybe in the future, it will be, it will overtake tissue. We can only wait and see. So I think genomics can improve cancer pathology if tissue is placed in a comprehensive clinical context. And for those of you who do see patients, pathologists don't get to interact with patients. We get the slide in the tissue. And it's really helpful for us if you share your knowledge with us, because that helps us decide what to do. I think if tissue is handled appropriately and with genomics in mind from the outset, remembering that what you put in is what you get out. We're working hard to optimize each step, but it also sometimes, despite our best efforts, we just don't get it right. And it would be really helpful if clinicians could understand that, sometimes we have to try again. As I mentioned, fresh tissue pathways are very difficult to set up, but they're ultimately worthwhile and the way of the future. And I think that we still have a lot of work to do in terms of improving our understanding of cancer biology. And as Nirupa mentioned, I think the Tumor Advisory Board is going to be an important player in bridging that gap between research and emerging technologies and service delivery or diagnosis. So I know that's been a lot, but I just wanted to say, don't panic and call your friendly local histopathologist. If you can't find your friendly local histopathologist, please feel free to drop me an email. And for those of you who start to engage with the GLH and cancer testing, please do refer complex cases to our GTAB, because we'd be happy to help whenever we can. So thank you, and I'm happy to take questions at the end or in the chat.
Thank you very much indeed, Nish and Nirupa, for that fantastic overview of cancer genomics. And I should have said at the beginning, please do put any questions in the chat, because some of our speakers will have to leave before the Q&A session at the end, and they will answer them in the chat. We'll pick up any leftovers at the end, but don't use the Q&A function, just use the chat function. So moving swiftly on, and thank you, Nish and Nirupa, for sticking exactly to time. We're now moving on to discussing our Lynch syndrome project. This is being led nationally by Dr. Adam Shaw and Dr. Kevin Monaghan. Adam and Max are going to be presenting this. Adam is a clinical geneticist at Guy's and St Thomas's, and leading the Lynch project with Dr. Monaghan, who is a gastroenterologist based at St Mark's Hospital. And Max is our pathology lead, so another go-to pathologist for any questions that you might have. So over to you. I think, Adam, you're kicking off. Thank you.
Thank you. Good afternoon, everyone. So yes, I'm Adam Shaw. I'm a consultant in clinical genetics, and I co-lead this project with Kevin Monaghan from St Mark's north of the river. So Lynch syndrome really is at the intersection of common cancer and rare disease. So named after Henry Lynch, he was studying families in the 1960s and 70s with a high prevalence of colon cancer, but we now recognize that it's a condition that predisposes to a range of cancers, both in the gastrointestinal tract and also elsewhere in the abdomen and urinary tract, most common being colon and endometrial in women, but we do see other tumors as illustrated there. And it is for a rare disease quite common, affecting 1 in 350 people. And so what that means on a practical level in cancer care is that maybe about 5% of people with colon cancer may have an underlying diagnosis of Lynch syndrome. And so with that in mind, NICE recommended back in 2017 that all patients diagnosed with colon cancer should have a screening test by either immunohistochemistry or microsatellite instability for Lynch syndrome, and then in 2020 the same recommendation was made for endometrial cancer patients. And the immunohistochemistry is looking at the 4 mismatch repair proteins, which we know are instrumental for repairing the kinds of damage we see in these tumours, and are faulty in people with Lynch syndrome. So just to illustrate, this was one of the first people I saw as a consultant 10 years or so ago with Lynch syndrome. She came with a diagnosis of endometrial cancer, and she'd had breast cancer in the past. And the pathologist had noted on the resection specimen that she'd had a small focus of tubal dysplasia. And so actually a gynecologist referred her because she thought she might have BRCA-related disease, hereditary breast ovarian cancer. So we tested her for that, and it was normal. And I just had, I just had a concern at the time. Oh, well, you know, ovarian and endometrial cancer, you know, are part of Lynch syndrome. She had no relevant family history, but we thought, well, let's just check that endometrial cancer. We did MSI at the time, and that showed that she had microsatellite instability in that tumor. And we went on to do DNA sequencing, and she had an MSH6 pathogenic variant, meaning she had Lynch syndrome. And she was pleased because we then tested her 3 children who were all negative for that pathogenic variant. But the wider family, we also cascade screened, and it turned out her cousin did have Lynch syndrome, and we were able to put that person in appropriate screening and risk reduction measures, which I'll talk about in a bit. And then just another case. This is someone who's become almost a friend. He's got my he phones my mobile quite often. He's a roofer from southeast London. I said, "Oh, you know, done much roofing?" He said, "Well, I put the roof on the Shard." I said, "I didn't think the Shard had a roof." He said, "No, it's got a flat roof. A lot of people don't realise." He was well in himself at the age of 68. He had a strong family history of colon cancer, gastric cancer, and endometrial cancer. But within a year of that diagnosis, unaffected, he'd had 4 separate primary diagnoses. He'd had a tumour of the renal pelvis, a urothelial cancer. He'd had a small bowel gastrointestinal stromal tumour. He had an adenocarcinoma of the pancreas, and he also had prostate cancer. And he had metastatic lung nodules. He was started on a combination of gemcitabine and cisplatin, and unfortunately had some myelosuppression, and so he had to come off that. And in the background, we were investigating this, and turned out that he had Lynch syndrome due to an MSH2 mutation, and he was started on atezolizumab, which was very successful in his case, and he's got a good response with the progression of disease at all sites, and he's currently remained very well. So what this illustrates is, I think, a case for change. We think only around 5% of patients with Lynch syndrome are getting that diagnosis. Data I'll present in a minute shows that we're only performing genetic testing in around a quarter of people who are eligible for it. And you know, NICE has recommended pembrolizumab for untreated metastatic colon cancer in MMR deficient tumours. And there's also a whole host of low-cost interventions that we can put in place for people with Lynch syndrome. We know, for example, that aspirin, if taken regularly, can reduce the long-term incidence of cancer by up to 50% in Lynch syndrome patients. We know that cancer rates can be reduced by lifestyle measures such as weight loss and stopping smoking. Women are offered risk-reducing surgery to reduce their gynecological cancer risk with a hysterectomy and bilateral salpingo oophorectomy in there around the age of 40, perhaps. And we put people on surveillance colonoscopy, which is every 2 years, and other surveillance strategies such as quantitative FIT are in trial. Just going through, sorry, this just illustrates the management strategies again. Colonoscopy slightly tailored to the gene pathogenic variant, MSH2 and MLH1, we start early at age 25. The other 2 genes a little bit later. And as we've said, it may affect the treatment that patients are offered in terms of either their surgical plan or targeted therapies. So this project started really when Bowel Cancer UK did a survey of the 4 nations of the United Kingdom, and found that patients were overall not getting this screening test, the immunohistochemistry, at diagnosis of bowel cancer patients. And for England, this was around 17%. And when they asked what barriers there were to testing, people cited funding, staff capacity, awareness, and local policy. So we then thought, well, let's look at this in a bit more detail, and we have partnered with the National Disease Registration Service, who is part of now NHS Digital, and they hold a registry of all cancer diagnosis through the NCRAS, and they also receive data from genomic laboratory hubs on genomic testing rates. So they're a good place to start and coordinate data. So what we did is we employed a data analyst who built a dashboard for us, and we can drill down at a regional level or a Cancer Alliance level, and also down trust level to see what proportion of cases are happening. The issue here is timeliness of data, and the NCRAS release data with around a 2-year time lag. So currently we have access to 2019 data. They are just about to publish 2020 data, which will now come on the dashboard. Anyone with an NHS email address can apply for a login to this dashboard. It's hosted on the Cancer Stats website. And this is too small for me to read, so just excuse me. But you can see that, say, for Guy's and St Thomas's, for example, we've got around 78% of people with colorectal cancer in 2019 who received immunohistochemistry on their colon cancer. Now, this is just one part of the pathway. We've got good reasons to believe that this has improved in intervening years, and that we now see much better uptake of immunohistochemistry. But of course, that's only one part of the pathway. That's what the pathologist then reports, but we then need to know that the clinical teams are actioning that result appropriately, and that on further tests that may be required are being performed, and those results are being actioned appropriately, and ultimately people are getting their diagnostic test for Lynch syndrome and being referred to clinical genetics or for ongoing management and screening. And so there's lots of steps there that can fall down. And so, as well as just knowing how many had their immunohistochemistry, we're also interested in how many people got that constitutional genetic test. And for colorectal cancer, of around 700 eligible people, only 28% were getting that test in 2019, and around a quarter of endometrial cancers. And what this shows is that it's really every stage of the pathway where we're seeing attrition. So of 6,000 colorectal tumours in the southeast region, around 42% got their MMR test, and of those that were abnormal, so we've got 82 here who had an abnormal MSH2, MSH6 or PMS2, but only 35% of those went on to get a genetic test, and of those with MLH abnormality, only around half of those were then getting the MLH1 promoter methylation test that would then be indicated. So, we're seeing attrition at every step. So there's work to be done to tighten that up. This is for endometrial cancer. The numbers are smaller due to time. I might flip over that. So what have we done to try and address this? We've appointed, or a Lynch clinical Lynch lead has been appointed to every GMSA region. Nationally, there are 7 regions. They get 2 PAs or consultant time to run this project within their region. And then also appointed as being a Lynch clinical nurse specialist who have just been appointed more recently to help roll this out and provide local training and support. And each Lynch lead and Lynch nurse will be working closely with the 21 cancer alliances throughout the region, who are really able to support this. And what are we asking? Well, we're asking for every MDT in England to nominate a local champion who can be responsible for the pathway. And that means ensuring the delivery of the NICE guidance, allocating responsibilities within the team, completing some training modules, linking to an expert regional network, and of course keeping up to date. The education modules are provided, and we're joining with e-learning for health to provide training modules. And this is how we've done. So there are 132 colorectal MDTs in England. Currently, we've got 106 champions identified, and a similar proportion, around 80% for endometrial cancer. We've got the regional Lynch nurses in place. We are encouraging these MDT members to take up the training, and what we're trying to establish in every GMSA region is an expert network that recognises that these patients will be generally managed locally on a day-to-day basis, but that local clinicians need support from a network. It's a complex multi-system disease that and so representation from an expert network really should cover colorectal specialist gastroenterology, obstetric gynecology, some representation from laboratories to interpret results, maybe dermatology and so on. Patients are at risk of sebaceous carcinoma and adenoma as well. So the aim is to set up these expert networks. This is really just looking at progress to date, but it's largely what I've said already. So I'm just going to hand over to Max, because we're a bit short of time, who's going to talk about pathology aspects.
Thank you very much, Adam. And yeah, it's a pleasure to be able to talk to so many people from such a variety of fields today. I think I'm going to essentially echo Nish, and it must be that we've got some sort of ingrained vulnerability that we always seem to have to think of plugging cellular pathology, but in the Lynch pathway, really cellular pathology is the start, and it's at the heart of testing for Lynch syndrome. And I felt that as I work in an arena where there is a bit of colour, that a simple case would demonstrate the more practical element of what we're doing. So to move from left to right on this presentation, the H&E shows us is the mainstay of diagnostic pathology in terms of the morphology, and as you can see, there's sort of irregular looking sort of glands set within this tissue, sort of seen or interpreted as adenocarcinoma. This is a colorectal case. And then I've put a couple of immunohistochemical slides. Unfortunately, they are the reactivity is denoted in brown. Unfortunately, you can get other colours, but for the MSH6, which is one of the domains, and there's 4 of them, that demonstrates that the cells within these irregular glands are, are positive. So that means that that is retained. But if we move to the image on the right, for me at least, then it demonstrates that there is loss of MLH1. So that is not showing brown within the glands, and the only bit of brown is actually a really nice internal control that we're given, which is the stromal cells surrounding the tumour. And then Adam, if we can move on just one slide. So really that's the reflex testing that is performed for all of colorectal and endometrial adenocarcinomas, but that list is ever expanding in terms of different sites of adenocarcinoma. And in this case, given that there was loss of MLH1, we know that that can be possibly relating to Lynch, or on occasion it can be of sporadic origin, probably more likely sporadic. So our next step, as denoted by the NICE guidance, is to for colorectal cancer, is to perform BRAF testing, and for this case that I've used as an example, there was a mutation in the V600 of BRAF, and that suggests it has a good positive predictor that this is a sporadic case as opposed to associated with Lynch, and so that this triage can then place this patient away from needing further workup and genetic counselling. Adam, I think I'm going to just leave it there, because I think it's I did have one more slide that just was suggesting that I think we're gaining traction in terms of, especially at the index testing in the southeast, and actually quite a reasonable number for both colorectal cancer and endometrial cancers in a recent survey, certainly undergoing index testing. And really the main barriers that were identified through that survey are probably as expected in most parts of the NHS, its staff, its resources, and its overall funding. Thank you, Adam.
Thank you, Max. Does anyone have any questions? I should be monitoring the chat.
There's been quite a lot of activity in the chat, Adam, while you've been speaking, particularly around training, and Kevin's been very kind, and various other people have been very kind in answering questions as well about that. So I don't know, Kevin, have you got anything that you wanted to add?
Well, just that we presented this project at Insight in New York last week, and around the world people are looking to the UK for how they can do what we're doing, and there's nowhere else anywhere that has anything like this in terms of delivery of universal testing. So I think the eyes of the world are on the NHS to see if the NHS can deliver on this. And I think in parallel to this, there are a number of other very exciting projects going on in the field of Lynch syndrome, including the delivery of colonoscopic surveillance via the bowel cancer screening program, which will happen from April of next year. So I think I think with it's a 2-yearly meeting. The next one is in Barcelona in 2024, and they're all saying they want to see what happens. They want to see the results. I think we're in a good place to deliver that, but it's a tremendous privilege to be part of this project and work with Adam and others.
Thank you very much, Kevin, and I would say from an NHS England perspective, they're very happy with how the progress is moving forward with this particular project. So thank you very much for your talks and for keeping to time. So we're going to move away from solid tumours onto haematological tumours, and it's another double act, well, actually a triple act. So I'm going to hand over, first of all, to Dr. Austin, and I'm going to get your name horribly wrong, but Kulasakararaj. And Dr. Gandhi is going to also speak, but we're very lucky that one of their patients, and thank you.
Okay, thanks, Francis, for that kind introduction, and thanks for the invitation as well. So what I'll try to do, as you said, is we will try to keep it short, and because of the diverse audience, apologies if some of it is too basic for some people, or if some of it is too complicated for other people as well. So if I move to the next slide, do I have control of the slides? Yeah, thank you. So I just wanted to take you through 3 patients I saw literally on one day, and it just sort of underpins the importance of genomic medicine, which as a hematologist we are very much aware of, but trying to see how we take about. So this was a gentleman who was 72. He was referred from his local hospital because he had a low blood count since 2018. His neutrophil count was 0.4. And interestingly, he also had a brother who had a stem cell transplantation back in 2016. And the patient who was referred to us was the donor who donated stem cells. And the brother had myelodysplastic syndrome and acute myeloid leukemia interface, but unfortunately died of transplant-related complications. And this gentleman was seen, as I said, in 2012. So slightly switching gears, here this patient had a somatic myeloid gene panel through our hematology malignancy diagnostic service, and he was found to have a DDX41 variant, which was likely pathogenic with a variant allele frequency. On the same day, and this was confirmed on the R347 panel using a germline sample. On the same day, we saw another patient who was 55, was referred from a regional hospital with an incidental low platelet count, and said, does this patient have an underlying MDS? His somatic panel was negative, but we did an R91 panel and we found that he had an MYH9 likely pathogenic mutation or class 4 mutation, which induces constitutional thrombocytopenia. And on the same day, I saw a gentleman in the morning who had 30 years, who had low platelets with some bleeding phenotype, but his maternal grandmother, mother, brother, son had bleeding and low platelets. And he also mentioned that his son has been concurrently investigated at Guy's and St. Thomas's. And when we did the genetics MDT in the afternoon, we had the result of the son come through, while I saw the father in the morning having an ANCA D26 pathogenic class 5 mutation. So this sort of underpins the value of genomic testing in this, not that I need to convince this audience. So if I look at familial myelodysplastic syndrome and acute myeloid leukemia. So acute myeloid leukemia and MDS or conditions which probably would rank about 10 to 12 common cancer in UK. We'd probably see combined about 5,000 to 6,000 patients in UK in a year. But whenever we had patients who had AML or MDS come to the clinic, because this is a disease with a median age of 65 to 70, patients will always indicate to us why did I get leukemia? And the common answer to that is we don't know. But at least in the last 5-7 years, in about a proportion of patients, we've been able to show that there is a germline predisposition for the presentation of leukemia, albeit in a later time point. And this has been captured by the WHO classification, both in 2016, where it divides the germline predisposition as indicated there, and the current WHO 5th edition has also incorporated the germline predisposition into a separate section indicating different variants identified which could lead on to the germline predisposition. And there is an additional classification which looks at the myeloid neoplasms and acute leukemia with the germline predisposition. So what we knew was that in familial MDS AML, these were genes which were mutated in sporadic AML. But the interesting aspect is half of the genes which are associated with familial MDS AML is also found in sporadic AML. So this is one sort of difficulty we always face when we are doing somatic acquired genetic panels, because quite a lot of genes we encounter are also mutated in the context of sporadic AML. And there are some genes which has got a high level of evidence, some moderate, and some which are emerging. So in the last couple of minutes, I just want to touch upon the few genes which has been linked with familial MDS AML. And up until the last few years, we only had few genes which were extremely rare, but in the context of familial MDS AML. But in the last 4 or 5 years, we've come up with this sort of gene, which is single gene, which has kept us all busy in the last couple of years, because now we know between 3 to 8% of so-called de novo sporadic AML cases are linked to an underlying germline defect in this gene called DDX41. So, and one of the things which we see in the context of familial leukemias and MDS is quite a lot of these conditions do not have a family history at all. And some of the recently described literature on the DDX41, this can extend to all ages as well. So the oldest patient we've seen with a germline DDX41 variant is 92. So indicating that this is something which is totally against the teaching which we were all taught, saying like you do not get these germline defects in older individuals, but it's essentially changing it. So and the other thing which as a hematologist which is important for us is donor-derived leukemia. Because if we are not aware of the presence of these germline predisposition and use asymptomatic family donors as stem cell donors, there is a possibility that the leukemia will relapse in the donor cells as well. And we've seen this time and again as well. So what do we know about DDX41? So this is involved in pre-mRNA splicing, which was initially described in 2015, but there has been a plethora of literature. As I said, around 5 to 8% of so-called de novo MDS AML have this variant. It's a very unique entity because it's late onset, associated with a normal karyotype, significant skewing towards male gender, close to around 4:1, and also a favorable outcome as well. And we put together a large series of cases along with a global group. It's one of the largest group of cases, which was put together around 400 odd cases, and essentially showing the same features which I showed before, showing that it is quite significantly enriched in MDS AML, and the median age of our cohort was this. So one of the key questions we had asked in this disease context, which I'll skip through, is about I'll skip to the next slide, is about the variation and the diversity of these mutations in different ethnic population. So since it was a large global database, we were able to ascertain the variants which were common in different populations as well, and how that would impact. And one of the important things which came out, because there is no estimated predisposition or cumulative incidence in carrier data as well. So they were able to show this, that there is a 45% chance of developing myeloid neoplasms in healthy carriers by the age of 90. So some of the so we talked about this transplant. So some of the things which we come across in the DDX41, predominantly in the laboratory aspect, and also in the use of cascade testing, is indicated there, because we're still trying to learn about it, because this is a targeted panel of single gene, but it has given us so many things to think about, and how we disseminate this information to patients, to utility of it, and also see how this can help us in both in the diagnosis, prognosis, and also management of these conditions. So collectively, we think that it's around 8%. It accounts for nearly 2/3 of the leukemia predisposition, autosomal dominant, late onset as well. We've not seen a case before 50 years, and common as germline predisposition. And quite a lot of patients do not have a family history of AML. I talked about the clinical phenotype as well. And this, I think I'd probably more call it like a BRCA1 for acute myeloid leukemia, because the 45% lifetime risk of developing breast cancer is not dissimilar. The only thing is the development of this disease is more towards the 60s and 70s as well. So I think it's important for other reasons, including cascade testing and also counseling of affected individuals. So I think to conclude, I'll probably say this is an age-agnostic approach for germline predisposition for myeloid neoplasms, because it affects even in the people in their 70s, 80s, and 90s. And it nearly 5 to 8% of AML MDS have got a germline predisposition. So sometimes most of the time, we only get the suspicion of an inherited predisposition when we do somatic gene panels. It's an incidental finding, and then we have to go back and discuss with the patient. So we definitely need germline confirmation for cascade testing. And it is a bit of a debate about, because not all the patients who are healthy carriers will manifest. It's a question of how do we monitor these group of patients as well. So I think happy to take any questions on it, but I just thought I'll bring in Alan, who has kindly agreed to come on board and have a discussion, and I'll also open up to other people if they want to ask questions. So, I don't know, Alan, if you're on the line.
I am. Can you hear me?
We can hear you. It would be good if we can see you as well.
Well, I think we could probably arrange that.
Thank you.
Can you see me now?
Yeah, I think so. Thank you so much, Alan, for appearing on this, and it's great to see you. I just wanted to say just a quick snapshot of how you were diagnosed and how you had a hematological condition.
It goes back to November 2020. I hadn't been feeling ill, though I'd noticed it was taking me an increasing effort to walk uphill or climb the stairs. I had a routine blood test, which I was due to have following the finding of a heart murmur. In fact, it had been postponed for 5 months because of COVID pressures at the hospital. On a Saturday evening, the day after the test, my phone started ringing insistently. I don't normally take calls from unknown numbers, but it went on, and it was my landline as well as my mobile, so I relented. And the caller was a 111 doctor who had been looking at the findings of the blood test, didn't like what he saw, said that there were numerous low blood counts, and it looked as if my immune system was suppressed, advised me to isolate rigorously and watch my temperature, seek a referral by my GP to a hematologist as urgently as possible. 10 days later, I saw a hematologist in my local hospital. It wasn't a cheerful experience, nor would you expect it to be, but perhaps it was even bleaker than it really needed to be. The consultant asked a few questions about my lifestyle and how I was feeling. He'd had the benefit of another blood test that the GP had organized. And he said, "You've got myelodysplasia." I'd never heard of it. So I said, "Well, tell me about it, please." And he said, "Well, it's not curable. If it's not treated, you may have 3 months to live. If it is treated, you could have up to 12 months. At which point I was dumbstruck. Silence ensued. Then he said, "Have you any other questions?" Well, I didn't really. Maybe I had so many I couldn't sort out which I wanted to ask. And I was out of his consulting room within a quarter of an hour. Went off to have a biopsy. The biopsy wasn't a success. I had to come back the next week for another biopsy. The day following, a different consultant phoned me and said that peering through his microscope, he reckoned I'd got AML. Well, I'd been back home, of course, and as I'd been told so very little about myelodysplasia, and I hadn't been given any handout to take away or anything like that, I'd gone onto the internet. And to the extent that I could understand what I was reading, I was increasingly horrified and terrified. So I exercised the right that every patient has under the NHS Constitution to ask to be referred to a different consultant at a different NHS hospital. And having made some inquiries, I thought that it would be ideal for me if I could be a patient at the haematology department at King's College Hospital. And best of all, you'll excuse me saying this, Austin, if I could be a patient of Professor Mufti. And happily, Professor Mufti took me on as his patient.
Thanks, Alan, for that. And Alan, these are conditions where we talked about and said this is acquired genetic things. But when was the first time you were made aware that your MDS leukemia could have been due to a germline mutation? And how did you take that?
Well, at my first consultation with Professor Mufti, he explained with beautiful lucidity and sensitivity the nature of the disease, how it might develop, how it might have been caused, how it might develop, what the potential options were. He said that various tests were needed: immune phenotyping, cytogenetics, molecular genetics. There would come a point at which we would have to take a decision whether to aim for cure or control. The curative treatment would be a bone marrow transplant, but he suggested, without going into detail, that there were significant risks associated with that, and normally it wouldn't be given to a patient over the age of 70, but I appeared to be a sufficiently fit 76 for this to be a possible option. But it would be essential to control the blast cells first. In my case, he'd expect me to be treated with a combination of azacitidine and venetoclax. And if we could get the blast cells down from 20% to 5%, we could then take a decision whether to go for a transplant or carry on with chemotherapy. We did another biopsy, and at my second consultation with him, he explained that the test had shown that I was hypocellular, meaning fortunately that the disease was spreading relatively slowly in my case, but on the other hand, with a hypocellular patient, it'd be too risky to use venetoclax. He was still awaiting information as to which gene was defective, but meanwhile, we'd start chemo straight away. This was at the peak of the COVID crisis when he said that there were 591 COVID inpatients at King's, some staff transferred from haematology to COVID duties. But he left me with a clear understanding of my medical situation, and while not giving me false hope, left me feeling encouraged that I was in the best possible hands, that we had a constructive strategy to deal with this. I had a third consultation with him about a month later. And at that point, in the light of the biopsy, he gave my diagnosis now as EB2 and said there were abnormalities in 4 genes. The significant one was DDX41, in which 47% of the genes are abnormal. He said we need a further skin biopsy to throw light on whether my condition had been inherited with significant implications for my family or acquired. But meanwhile, the good news was that DDX41 responds extremely well, as he put it, to treatment with azacitidine. And we would take the decision as to whether to go for a transplant after further treatment with azacitidine and in light of another bone marrow biopsy.
And how did you generally feel when you were told that there is a link, that a germline link with the DDX41? How did you generally feel about it around yourself and family as well?
Well, he referred me to a geneticist, Dr. Katie Snape, who was wonderful, talked at length with me, explored my family history. There were many different cancers in my family. I've got a fairly extensive family as well. We weren't able to track down how it came about that I had inherited the DDX41 gene. We couldn't identify, as it were, a predecessor sufferer of this condition in an earlier generation. We weren't able to identify all the cancers that different members of the family had had. So we were left with some uncertainties. And she also explored with me very thoughtfully and very helpfully the dilemmas associated with informing my family. And I came to the judgment after a lot of thought that on balance, it was better not to. I mean, my family knew that I had a blood cancer, but it was better not to burden them with information about DDX41 and the possibility that they might themselves have inherited this, the potential for this genetic mutation. They could be carriers passing it on to their own children. One of the factors that influenced me was that one of my nephews had been treated clinically for anxiety. He and his wife were expecting a baby, and I really didn't want to burden them with a whole additional source of anxiety, which I knew in his case might be really quite considerable. I recognized that from the point of view of medical research and medical professionals such as yourselves, it's unhelpful if a patient decides not to expose their family to this information, because it means you can't undertake cascade testing. And I'm sort of sorry about that. The one qualification I made to that decision was when my sister told me that she had now been referred to a hematology consultant because she had anemia, explanation of which couldn't satisfactorily be given in relation to heart surgery that she'd had and colon cancer that she'd had, and so thought she'd better see a hematologist. In fact, so I told her about DDX41 and what I knew. In fact, it then turned out that she was all clear from the hematological point of view. Okay. So while I personally, I'm being a bit hypocritical here, because I personally feel that I would always want to have all the information that I could have about my condition. And perhaps it's too patronizing to withhold that information from my family members, but that's how I felt at this stage I ought to proceed.
Thank you, Alan. That's quite clear as well. Loads of food for thought for us, and the genetics as well. So I think, want of time, I think we should stop there. But I'd like to thank you again for being part of this, and thank you for giving your time as well. And
I'd like to thank you. I was riveted by the earlier presentations. I think Nirupa said that pathologists don't normally get to interact with patients. Well, equally, patients don't normally get to interact with pathologists. So thank you for the opportunity.
Thank you so much. I think I'll hand over to Francis, and I've got Dr. Gandhi, who's one of my colleagues, who will present on the bone marrow failure side of things.
Thank you very much, both of you. That was really enlightening, and of course I work with Dr. Katie Snape, so I'm very pleased to hear that compliment. I had no doubt you had a good consultation with her. I'm handing straight over to Dr. Gandhi. Thank you very much. Do take over.
So thank you, Austin, and thank you, Alan. So I'm one of the other hematology consultants based over here at King's College Hospital with a special interest in people who have bone marrow failure. So this is the third of the prior talks that we have in hematology associated with genomics, and Austin's beautifully dealt with the issues that we have with predisposition to myelodysplastic syndrome and acute myeloid leukemia and the genes associated with it. And I'm looking more towards the other end of the spectrum, where you've not quite developed myelodysplastic syndrome or acute myeloid leukemia, but rather you're still dealing with issues with low blood counts and bone marrow failure. Again, apologies. I know the audience is fairly diverse, and some may find this to be very, very basic, and some may find this far too specialist. So I'll try to hit a middle ground, but do stop me if things are not clear. So we are often referred patients mainly through primary care, but also through other hematology centers where they've initially reviewed patients for low blood counts. Reason could be XYZ. The most common causes for low blood counts have usually been dealt with, such as iron deficiency and vitamin B12 deficiency, autoimmune causes, so on and so forth. But if there is a lingering suspicion that this is perhaps some kind of genetic basis, and that genetic basis could be either inherited or acquired, then these patients come to King's. We can also be referred patients who could be having normal blood counts, and there are reasons why this may happen, because patients may just have isolated macrocytosis, and sometimes there's a strong family history of cancers or something like that, which makes people investigate. And when they do investigations, there are genetic changes that are found, and we call this as clonal hematopoiesis of indeterminate potential, where you could still have normal blood counts, you could have macrocytosis, and you find a mutation in one of the acquired genes, which is at a low level. That just suggests this is a harbinger to something that may develop as the years progress. On to more the cytopenic side of things. On the cytopenic side of things, you can have a picture where the bone marrow is essentially empty, where we call this as aplastic anemia or aplasia. And as it starts getting more disorganized, you enter the spectrum of myelodysplastic syndrome. So long as the dysplasia element is less than 10%, it's more the domain of an empty bone marrow or a hypocellular bone marrow. As the disorganization progresses beyond 10%, it's more MDS. But even within MDS, you can have a picture where the bone marrow is essentially empty with a lot of disorganization. And this entity we call as hypoplastic MDS. So we see a whole spectrum of disorders, from people having normal blood counts with mutations that were detected because we tested for them, to patients who have low blood counts with an empty bone marrow. There are abbreviations and names that we've found for these, CCUSs and ICUSs, which briefly stand for clonal cytopenias of undetermined significance. And we can progress to the stage where the disorganization is so much that you call this as myelodysplastic syndrome. And a step further would be acute myeloid leukemia. So from a hematology perspective, this is the spectrum that we tend to see, because based on the tests that we do, bone marrow tests, the liquid flow cytometry tests, molecular genetics, and other bits that we do, the diagnosis that we would often reach is somebody having MDS or aplasia, or a condition called as PNH, which overlaps and transcends between these two. So from a clinical hematology perspective, these are the conditions that we would see. And as is shown in this diagram beautifully, and also shown by Austin previously, all of these hematological conditions have a propensity to progress towards acute myeloid leukemia. But the more important thing is that all of these conditions have a very significant genetic overlay over it. And when I say genetic, I include both inherited as well as acquired. So there are genetic changes that you could be born with, and there are genetic changes that can be acquired, which all are very closely intertwined and linked to all of these hematological conditions. So some could be inherited conditions such as the Fanconi anemia genes, the telomere biology genes over here, or the ribosomal biogenesis genes over here. And these are often monogenic disorders with which follow Mendelian pattern of inheritance and cause bone marrow failure. Likewise, some of these conditions over here that we see, such as PIGA gene and STAT3 genes, are genes which are usually often acquired. But there is a growing understanding and a feeling within the bone marrow failure community that these are not as simple as that. For example, people who are born with telomere biology disorder or a ribosomal biology disorder tend to develop bone marrow failure, but the progression tends to happen because of a second hit. And that second hit could be an environmental factor or other associated conditions, or often a second acquired mutation. Likewise, people who have what is deemed to be acquired aplastic anemia or myelodysplastic syndrome, again, is not simply an acquired thing. Just like the DDX41 story that we've just heard, there is a growing realization that often we tend to have certain genes which make us susceptible, which make us prone to developing MDS. So it is not as strictly acquired or inherited as we make it out in this diagram. And I'll follow three stories which talk about genetic changes and mutations, which highlight the kind of dilemmas that we face in the world of bone marrow failure, and issues that and our wish list as to what we would want going forwards. So this diagram kind of summarizes the portrait that we have for inherited bone marrow failure disorders. Over here, we have the telomere biology disorders. They're often associated with people having premature graying of hair, often can have multisystem complications such as pulmonary fibrosis or cirrhosis of liver, but by far the commonest complication remains bone marrow failure. At the other end, you have DNA repair defects over here, the Fanconi anemia genes. We have the ribosomal biogenesis defect genes over here. And you have a host of other constitutional thrombocytopenia genes, including genes that make people prone to developing acute myeloid leukemia. And this picture kind of summarizes the spectrum of bone marrow failure disorders that we tend to deal with. Now we'll talk about the first patient. We had a young gentleman who came for an elective circumcision, and he was noted to have a slightly low platelet count of 109. The rest of his parameters were entirely normal. His blood counts were normal. He was essentially asymptomatic. Interestingly, he talked about having a skin biopsy done on his penis, where he was found to have a squamous cell carcinoma, which is quite unusual. But he had had this follow-up for 5 years, and he was in the all clear for this. Like I mentioned, a lot of patients with macrocytosis are often the people who get referred to us associated with thrombocytopenia and his young age and this history of penile skin cancer. And then he gave us a further history about a very strong family history of lots of people suffering from cancers, prompted further investigations. We did a bone marrow, which was quite hypocellular. And there remained this concern whether this was a genetic condition, a genetic bone marrow failure disorder. And at King's, we are fortunate to be able to do two sorts of panels: the acquired panel, which can sometimes overlap with the constitutional germline bone marrow failure panel. And we found a defect. Sorry, this is not moving forwards. One sec. Yeah, we found.
Can I just say a couple more minutes? So if you could move through quite quickly, that would be great. Thank you.
Oh, perfect.
Sorry to
Perfect.
interrupt.
No worries, I'll move that. So we found this defect in this third gene, and I will skip through if I can make the slides move. Yeah. So this gene has been described as was one of the first genes described when genetic testing was done in acute myeloid leukemia, and subsequently there have been a lot of corrections, and we've now found that this is often seen in patients with aplastic anemia, bone marrow failure. So if you follow the story up until here, you thought you've got an answer. You have low blood counts, you found this gene, and this has been reported previously. And pronto, the story ends over there, but hardly, because worldwide database studies subsequently have shown, lots of genetic studies have shown that this has got a very high prevalence in the community. If 1.2% of the population is known to have this defect, clearly it is not a gene which is considered to be a constitutional or a germline gene associated with bone marrow failure. Furthermore, we've done tests and studies. I'm not able to move this. So the previously, the example that I was going to show previously was that we've done functional assays to show that, although this is a slight variation, there is enough telomerase activity preserved, and that with a high prevalence such as this in the community, this is unlikely to be the cause for a bone marrow failure. Having said that, we've seen some bit of segregation. So nearly 3% of the population who have aplastic anemia tend to have this genetic defect. So there is certainly some amount of segregation, but other than that, this is not a direct one-on-one association. I'll move to the other slide next. I will have to rush through quite a few of this. Again, a lady who presented with MDS in this instance, she's got a very strong history of Hodgkin's lymphoma. She's had breast cancer treated twice, and she's also had a genetic defect, constitutional defect of her ureter, which was repaired. There was no family history, and clinical exam was entirely unremarkable. I'll move to the next slide. We found a variant in one of the genes, which is called as the SPDS gene. This is the gene which is associated with neutropenia and exocrine pancreatic insufficiency. And this is again associated with the syndrome, which we call as the Schwarzman-Diamond syndrome. It's one of these pre-leukemic conditions with a strong propensity to again develop MDS and AML. In this instance, we've got a direct hit. This is a gene defect that has been known and identified with SPDS. The only catch and the only caveat is that this was found in the heterozygous state. So you have somebody who's developed cancers, you found somebody who's developed MDS as well, but this is in the heterozygous state and per se. Can we move? Yeah. There isn't enough evidence, in spite of knowing that this is a direct gene associated mutation linked to MDS. We cannot for conclusively say that this is one of the innate limitations of what we have about what we can report and what we cannot. I think I'll move on to the next one. And finally, the third case that I'd like to show, and this is a straightforward case, somebody, fairly young chap, no real problems in life, was found to be neutropenic, long history of infections from his childhood onwards. He had a bone marrow test. His bone marrow was hypocellular and had features of aplasia. We've done lots of tests, genetic tests. Move to the next slide. There's nothing really on examination either from his father's side, from his mother's side, or on his clinical examination to suggest anything that was constitutional. Next slide. We've done the neutropenia gene panel, which is the inherited gene panel. And let's go to the hit. What we found this mutation. Now there's this one very big family from Ireland, and there's a very good case report reported in BGHIM just based on that. Same gene defects, same phenotype. This is X-linked Wiskott-Aldrich syndrome associated neutropenia. He's been started on treatment. He's been counseled appropriately. And let's move on to the next slide, please. This is more along the domains of what Katie and her friends have to deal with. When we find something which is 10, which is fantastic, we know it's out and out pathogenic, but very often we deal with this middle yellowish greenish shade of lots of variants of uncertain significance. There's some family history of cancer. There's some family history of bone marrow failure. Lots of testing cannot definitely or conclusively tell us what is the strength of this classification. Let's move on to the next slide, please. So in the field of hematology, when we're dealing with bone marrow failure, we deal with lots and lots of issues, but very often we mainly rely on the clinical side of things, people having young age, people having other family history, people having other malformations, other systems being involved that make us think about bone marrow failure. But genomics is so integral to what we find, what we decide, and what we talk about. Let's move to the next there are lots of issues that we have to deal with when we talk about bone marrow failure and find a mutation. We have to think about anticipation, particularly with the telomere biology disorders. We wonder about variable penetrance. We see mutations that can transcend between the constitutional panel and the acquired panel. Often and very often there is a second hit. In spite of having a germline or a constitutional bone marrow failure disorder, there is a second hit which drives the disease forward. We very often have to work with dermatology, liver, respiratory colleagues with a very collaborative approach to how we manage these patients. And integration of genetics is so very common to all of the work that we do in this field. I'll just like to finally end with one slide. So we do have this, like I mentioned, integration of genomics is so integral to how we work in bone marrow failure. We have to be mindful of many things. There is a significant degree of clinical genotypic association. We worry about penetrance, disease anticipation. We need larger databases which talk about geoethnic populations so that the risks from variants in genes are properly described. And finally, end it with the next bits. This is where we're looking to, which is family linkage analysis, very important. This is where Katie Snape and her team who work with us tell us so much more, and it's been a real opportunity and education for us to work with her. We will need more genome studies, whole genome studies going forwards. Functional tests, we need to link up with research laboratories across who do particular work and perform functional tests where we can. And multidisciplinary input is so very relevant to the work that we do. I'm sorry, my presentation's been slightly rushed, but I hope I've managed to give a slight synopsis of how we deal with the bone marrow failure side of things in hematology.
Thank you very much indeed. It was really fantastic to have that overview of the whole area. Thank you. I'm going to move swiftly on. Please do keep putting questions in the chat, because I think we probably won't have much of a Q&A session at the end. But last but not least, I'd like to introduce Dr. Debs Sarkar, who is co-lead for the Genomic Laboratory Hub and GMSA as cancer, and a medical oncologist in Guy's at St Thomas's. So over to you, Debs. Thank you very much.
Thank you, Francis, and thank you for the opportunity to speak at this wonderful event. So I'm going to talk to you about targeted therapies and have a bit of a discussion also in terms of increasing role of circulating DNA. So I'm a medical oncologist, and I have two main hats, one of which is to run a number of early phase drug development programs, and I have a big interest in precision medicine, and obviously that naturally falls very much in line with my role in GLH. Just make sure I can. Okay, so this is an overview of my talk. So really, fundamentally, this is all about how we deliver precision medicine to patients with cancer and integrate that with genomics. And, you know, there are a number of kind of challenges for us and a number of questions that I think we in part have worked out, but some of which we're still you know, create challenges and you know, are things for us to try and improve going forward. So these are some of these, and just have these in mind as I'm kind of talking through the slides. So, you know, first of all, what are the kind of practical challenges for how we translate, you know, tumor sequencing data actually into a kind of clinical decision for our patients? How do we actually make sure that we embed genomics more in a more integrated way and into our diagnostic and treatment pathways? How do we use that genomic data to support use of, in particular, targeted drug therapies? And in particular, we really want to make sure that the targeted therapies that we give improve patient outcomes. And it's not just about the kind of standard of care therapies, because there's a whole raft of investigational drugs that are out there. So how do we use genomic data to increase the number of patients getting access to targeted therapies beyond those approved therapies? So this just is a kind of pie chart of metastatic non-small cell lung cancer and the driver kind of oncogenic changes. And you can see there's a whole raft of you know, oncogenes and gene rearrangements and fusions that are responsible. You know, and over the last 10-20 years, we've been increasingly being able to kind of slice these individual sections of this pie chart. So for us, coming at this from a perspective of precision medicine and genomics, part of this is, you know, central to everything that we do within the GLH and GMSA. How do we ensure patients with cancer get equitable access to high quality genomic testing? So how do we make sure that we cover all of those different elements of this pie? But also increasingly, how do we make sure that we use that genomic data to actually match them to a precision medicine? And this is really important, because if you take the example of non-small cell lung cancer, This slide actually just goes through the FDA approvals for targeted therapies for non-small cell lung cancer over the last 10 years. The section at the top is related to gene rearrangements of fusions and individual drugs. And then on the bottom here are oncogene-driven changes. And you can see that, you know, over the last 2 or 3 years in particular, there's really been an explosion of the number of drugs that are coming through. So these are just standard of care therapies. And the other point that I'd just like to make is a lot of these drugs, which initially might get tested in a fairly advanced setting, often then get moved earlier in a patient pathway. So for example, this drug here called osimertinib, which is a drug against the non-small cell lung cancer that has a EGFR T790M mutation, originally approved for more advanced second line cases, then got moved to first line, and then now has been approved in the adjuvant setting. So this just gives you an example of one tumor type, but you can see here, and hopefully this won't make you too dizzy, this is actually the range of approvals both in the US and in Europe for targeted therapies over the last two to 3 years. In fact, this is actually between about 2019 and 2021. And you can see some of those are already listed in the previous slide with non-small cell lung cancer, but some of these are what we call tumor agnostic approvals, where they are not linked to a specific tumor type, such as lung cancer. And so we have, for example, here, entrectinib, which is a drug against NTRK fusions, and pembrolizumab for patients with high tumor mutational burden, which Nirupa mentioned earlier. So this is the kind of challenge for us to be able to keep up with, you know, the rapid change in terms of not only drug approvals, but drugs which are coming through in terms of investigational targets and investigational therapies. So how do we kind of keep track of that and make sure that we've got that kind of future all kind of mapped into what we're doing from a genomic perspective? Okay, so if we just actually just take a step back and actually look back to what was happening when the kind of first series of large comprehensive genomic profiling was done in the last decade, you can see that, and these are big, you know, so these are very high impact cancer centers in the US and Canada and in France. So very big cancer centers. And you can see here that when this comprehensive genomic profiling was done on a number of different types of, using a number of different types of next generation sequencing, the overall percentage of patients that were determined to have what would be regarded as an actionable mutation was about 44%, but actually the percentage that then went on to receive a matched therapy was actually a lot lower. So there is quite a significant substantial loss of patients between what we would normally regard as being an actionable target and then actually getting or receiving a matched therapy, either in the context of a standard of care therapy or an investigational drug. So how do we go about trying to ensure a kind of standardized approach to cancer genomic testing? So a lot of what we've been doing within the GLH and GMSA is really about, at the moment, trying to deliver high quality testing in an efficient and timely manner. And the way that we do this is that we have solid cancer large next generation sequencing panels. So this is whatever cancer type you have, you'll have roughly speaking the same large DNA plus or minus RNA panel. We obviously have a national approach to implementing these next generation sequencing panels, and Nirupa has talked a little bit about the National Genomic Test Directory, and increasingly what we're trying to do within that test directory is trying to make sure that those kind of future investigational targets are also included in terms of what's being routinely tested. We have started to introduce circulating DNA programs, as well as whole genome sequencing in selected tumor types. And in terms of what we think will happen in the future, if we can do a little bit of crystal ball gazing, we can think about how potentially whole genome sequencing might be rolled out across many more solid cancers, how we might integrate with other types of omic technologies in terms of not just thinking about genomics, but proteomics, metabolomics, increasing use of ctDNA testing, circulating DNA testing for things like minimal residual disease, and to determine the resistance mechanisms for targeted therapies. And I'll talk a little bit about more about that in a few slides. And also how we might improve things such as integrated molecular pathology reporting. And finally, pharmacogenomics is an increasing important area in terms of many of our standard of care therapies. So one of the things that we can think about in terms of how we use genomic data to support use of targeted drug therapies to improve outcomes is the increasing access to what are called tumor agnostic therapies. And I gave you the example of NTRK, which I'll talk in a bit more detail about now. So what is a tumor agnostic therapy? So a tumor agnostic therapy is basically a drug that can be used to treat any kind of cancer, regardless of its tissue of origin, and can be used when the tumor has a specific molecular alteration that is targeted by that specific drug. And as you'll see in some slides I'm going to show, they often demonstrate quite significant clinical activity across histologies, and they will have an absence of histology-specific mechanisms of resistance. And so, NTRK has really been the kind of poster child for this wave of tumor agnostic therapies. And this slide on the this picture on the left is from a BBC News article talking about NTRK inhibitors as a revolutionary new class of cancer drugs when the first NTRK inhibitor was approved back in September 2019. And the CR UK blog talking about how this new breed of personalised cancer medicine is now being approved in England, and really what the implications are for patients. The challenge that we have is that, for example, for NTRK gene fusions, whilst they occur in a range of adult and paediatric cancers, for many patients with the common solid cancers, such as, let's say, colon cancer, pancreatic cancer, melanoma, lung cancers, it's really trying to find a needle in a haystack. You can see here the prevalence of these NTRK gene fusions is in the order of 1% or less. However, in certain much rarer conditions, so this rare cancer called salivary mammary analog secretory carcinoma, secretory breast cancer, and certain types of pediatric cancer, which are relatively uncommon, they're found at much higher prevalence. So for many of the solid cancers that we have, trying to identify these NTRK gene fusions is like trying to find a needle in a haystack. But the reason that it is so important is because these class of drug are really transformative in terms of what they can do for patients in terms of response. So the kind of top line data from one of the first NTRK inhibitors called entrectinib showed that over 60% of patients developed what's called a clinical or partial response, including, as you can see from this waterfall plot, so these are all individual patients and the percentage shrinkage of cancer from the point before they started the cancer. And you can see many patients, the cancer has gone completely. And in this group of patients who have very advanced cancer, often with no other therapy, patients are often living not only for many months, but often for many years. And you can see from the kind of table on the right that the response rates and what we call the duration of response is very significant. So this is not just drugs which cause a shrinkage in a small number of patients and then resistance develops very quickly. In the majority of patients, this duration of response can often be very prolonged. So these are really transformative therapies. And as I said, for us, it's really trying to identify these needles in a haystack. So we've got two NTRK approved therapies now through NICE. One is called larotrectinib, the other one entrectinib, and these are approved and funded now. And it's not just about NTRK. There are, in terms of what is currently available from a US perspective, in terms of approvals from the US FDA, there's actually 4 indications now, one of which is NTRK. The other one is mismatch repair deficiency or microsite instability or tumor mutational burden high, which means that you can access immunotherapy. And most recently, we've had approval for solid tumours with BRAF V600E mutations with a combination of a BRAF inhibitor and a MEK inhibitor. And thinking about what's going to happen in the future, over the next few years, we anticipate a whole range of these tumour agnostic approvals coming through. And I've just listed some of them here. And even last month, on the cover of Nature Medicine was a trial that we have been running here at Guy's of a drug called pralsetinib, and how it's been able to very effectively, in a very similar manner to NTRK, target fusions in a gene called RET. So this is a really exciting area, and this is really going to be increasingly important for us going forward in terms of trying to match very specific drugs to therapies, to specific gene abnormalities. But it's not just about standard of care therapies. We are trying to obviously increase the number of patients getting access to targeted therapies beyond approved drugs. So how might we do this? So there's two ways to do this. First of which is to try and think about a clinical trial. And for patients who often have, let's say, a rare cancer, this can be quite difficult. If you've got a rare cancer with these with these particular abnormalities, you might struggle to get access to a therapy. So we now have two trials, for example, in the UK, which are currently running or about to open. One of which is a trial called Tapestry, which I've just shown the schema for here on the left. And the other one is a trial which is run through Cancer Research UK called Determine. And these are what are called pan-tumor trials. So these take patients, whatever your cancer type, and you can see here they have multiple arms. So depending on whether you have a specific gene fusion, as listed here, you have high tumor mutational burden, you have mutations in genes such as PI3 kinase pathway, HER2, BRAF, etc. You can get access to that specific therapy. And the important thing about these trials are, first of all, that the enrolment is via our local testing here within the GLH. Secondly, they often include a range of patients, both in terms of adults, but also in terms of pediatric and teenage and young adults. And also, at any one time, this is what we call a modular trial, where, in essence, a certain number of patients will be recruited, and then other cohorts potentially will be added, or new combinations might be added. So these types of trial really have the ability to, over not just a few months, but often over a few years, to be able to really enable decisions about activity of specific drug therapies against gene targets to really be determined. Now, obviously, every patient is not necessarily suitable for clinical trials due to a number of issues, including potential comorbidities or performance status. And so we should always consider how we might request access to therapies, often direct to pharma, what are often called compassionate use programs. So these are the kind of things that's really important for us to understand and consider, and especially in the context of what we're trying to do within a genomic tumoury advisory board. Finally, just in terms of circulating DNA, I just want to give you, a bit of a broad overview in terms of the potential utility of circulating DNA, or what we call liquid biopsies. They can be used across a number of different points of a patient's pathway or journey. So in terms of helping with diagnosis. So, for example, there's currently a clinical trial which is being run called the Galeri trial, which is actually an early detection trial trying to understand different methylation patterns from circulating DNA and comparing that to non-tumor DNA. And then, thinking about potentially after a patient might have had curative surgery, what the presence of what's called molecular residual disease or minimal residual disease might enable us to be able to detect recurrence early after surgery. It also might enable us to guide use of certain types of therapy after surgery to try and reduce risk of recurrence. In terms of surveillance, after a patient might have had curative surgery, we can think about what the potential utility of circulating DNA is. And then probably where we're using it most at the moment is really around treatment selection once a patient unfortunately has had recurrence. What hopefully we'll be able to understand more is in the future when patients might have, had their first line of therapy, but then develop progression, to try and understand what the specific resistance mutations are, then allows a very precise way for us to be able to target those resistance mechanisms in a much more personalized and specific way, rather than trying to do a one size fits all. So this really just is an overview of what I see is really the potential utility of circulating DNA. And just to highlight that at the in terms of, we currently have a national GMSA project looking at the utility of circulating DNA for patients with newly diagnosed non-small cell lung cancer at the point that they're being considered for potential first-line therapy. So that particular ctDNA pilot program is just about to start, and we're really looking forward to seeing what data we get and hopefully helping a number of patients and really planning how we then devise other programs for other tumor types. Finally, just in terms of what is the role of a genomic tumor advisory board, Nirupa and Nish have talked a little bit about this in terms of trying to obviously help with those kind of things that we've just talked about, in terms of trying to understand what the specific genomic aberrations are, how we might match that to standard of care therapies, clinical trials, or off-label drugs, and obviously how we link the tumor board, genomic tumor advisory board, to tumor specific MDTs is really important. And then finally, we've talked a lot about what potential utility of, or detection of, potential pathogenic germline variants, and linking that with clinical genetic services. These are the kind of core members of our Southeast GLH GTAB, and here's an example of a next generation sequencing report. This is actually using a liquid biopsy report. This is actually of a young patient with colorectal cancer. And we actually identified 2 gene alterations in this patient, one of which is HER2, the other one is RNF43. If you look on this very generic report given by Foundation Medicine, it doesn't really talk about any particular clinical trials for this type of approach. Or for these particular genes, but within the context of a genomic tumor advisory board, we're then able really to be able to understand what the clinical context is, to be able to review the somatic findings, and then for this particular patient, we're actually able to give specific recommendations in terms of clinical trials, in terms of these particular actionable variants that have been identified. And one of the ways that we're doing this is that we have a particular program called the Experimental Cancer Medicine Centres Trial Finder, or ECTF, and the ECTF enables us through this collaboration with Cancer Research UK to be able to filter according to a tumour type, according to a specific gene mutation, and you can see this particular patient. This came up with a particular trial that we're running here at Guy's, looking at this class of drug called porcupine inhibitors against this particular mutation called RNF43. Francis, I'm slightly aware of the time. I might just, I'll probably just wrap up. I was going to talk a little bit about clinical decision support tools to help determine actionability, which is another thing that I think is really important within the context of a genomic tumor advisory board. And finally, just very briefly, just to mention how we might improve things further forward, going forward from here, in terms of trying to link actual genomic data directly to trial databases such as the EC Trial Finder. So we had a collaboration with a US-based AI company called Inspirata, and they've got this particular program called Trial Navigator, which is based on natural language processing to try and pick out data directly from reports, including genomic reports. And so we did a retrospective review of a number of patients that had been referred to us for early phase clinical trials, and the ability of Trial Navigator to really identify suitable trials. And so in this situation, we're actually able to pick out genomically matched trials for over 70% of patients that hitherto otherwise would not have been identified. So I'm sorry, it's been a bit of a run through, but I just, just to conclude, I think obviously I've hopefully shown you that, we've got a number of initiatives that are likely to have increasing impact for cancer patients over the next few years. There are a number of kind of challenges in terms of how we translate that sequencing into clinical decision making, and things like tumor agnostic therapies, use of ctDNA, and clinical decision support tools, including AI, could hopefully help increase the number of patients getting access to precision medicine in the future. So with that, I'll conclude. Sorry, it was a bit of a rush at the end. Apologies.
Thank you so much, Debs. And I think your final slide actually said it all. I think genomics has the potential for a huge amount of impact in cancer. It already has, but it's, you know, more and more, and those new technologies are really exciting. So as a non-cancer geneticist, I've learned a huge amount through this session. Thank you very much indeed. And we would really like some feedback. So I think Makeda has a final slide with the QR codes, hopefully, but if not, you will get a link as well. And please feedback, because we plan to do another festival in 6 months' time. And so we'd like ideas about future festivals, what you want to know about. And I'm going to hand over to my colleague, Sean, who is going to do the final wrap up.
Yeah, thanks, Frances. And obviously, firstly, I'd like to thank all the colleagues who've presented today, because they've done a great job. It's fabulous to have such insight and breadth as well. And particularly thanks to Alan as the patient who kindly attended, and I think highlighted the key and really critical importance and the complexity for patients and family as we sort of generate this sort of complex genomic data. So thank you very much, Alan. Finally, big thanks to everybody for attending. And as Frances said, please fill in as much information and feedback as you can provide us. That's very helpful. Makeda has recorded this, and this webinar will be uploaded onto our YouTube link, and she will send that link to all registrants. So if you haven't had time or wish to browse again, please do so, and hopefully add some quality. And I only wish you the best for the rest of your busy day over the next few hours. So thank you once again for attending and joining us.
Thank you, everybody.